So in our discussion today, we'll see a little bit about the commonly encountered vascular abnormality in a lot of settings. Atherosclerosis, we'll look at how it's formed, the clinical morphology, the factors, and so on. And we'll also look at aneurysms and dissection. We'll cover hypertensive vascular diseases, congenital anomalies, and all the others in your next lecture. So vascular pathology basically has two mechanisms. It can be either narrowing of blood vessels or a complete obstruction, or weakening of the blood vessel walls. So we'll just see a sample sample pathologies from each of these two mechanisms: narrowing in the case of atherosclerosis and weakening in the case of aneurysmal abnormalities. So just to revise, I'm sure you know this from your physiology, how our vessel system is organized. So you have the arterial system where the oxygenated blood is pumped through, and you have the venous system where the deoxygenated blood is pumped through. So the basic morphological difference between these two vessel groups is the arteries, particularly the big arteries, the aorta, and the muscular arteries. They are characterized by these concentric, the media of the blood vessels, concentric smooth muscle layer. So it has a very thick smooth muscle layer. The media has a very thick smooth muscle layer, and this helps it maintain the pressure, the higher pressure that is seen in the arterial system. So as you go way down into the lower level of circulation, into the arteriole, the smooth muscles, how packed the smooth muscles are will decrease, and it will all disappear when you reach to the capillary level where you don't see any smooth muscle component. So the venous wall has to do with accommodating vascular flow rather than maintaining pressure. As you know, the venous circulation has the lowest pressure, and when you reach into the larger level, it almost becomes zero. The pressure becomes zero. So the venous system is a low pressure zone, whereas the arterial system is a high pressure zone. And this blood pressure is mainly maintained at the level of the arteriole. So when you look at the structure of the normal vessels, it is organized in these three layers. It's just a revision for you guys. And we have the intima, which is mainly made up of the endothelial cells. These are the endothelial cells, the flat cells. And then also part of the intima is the subendothelial connective tissue here. Okay, so the endothelial cells and the subendothelial connective tissue form the intima, and then they are separated from the next layer, the media, by this elastic fiber known as the internal elastic lamina. So the media forms the second layer of the vessels, and it is composed of smooth muscle cells. So the medial layer is separated from the adventitial layer by another elastic fiber known as the external elastic lamina, and after that you would see adventitia, which is mainly composed of a loose connective tissue. You might see some smooth muscle fibers, and also the vessels that supply the vessels, or the vasa vasorum, within the adventitia. So it is arranged this way. So this is the histologic appearance here. Okay, this one, the endothelial cells along with the internal elastic lamina, and then you have the the intimal endothelial connective tissue. You have the muscle. You have the muscle wall next. The muscle wall and the adventitia. And when you compare compared to veins, you see the muscular wall is much more thickened in the arteries than in the veins. See, the vein is usually easily collapsible because it's a low pressure vessel. So the vascular wall cells and their response to injury. So the two components of the vessel wall are very much important for any response to injury. The first one are the endothelial cells, which are very important. We'll see how. And then you have the media smooth muscle cells. So endothelial cells are very dynamic. They have both synthetic, they can produce hormones, they can produce growth factors, they produce cytokines, and they can activate other cells. So they can mediate inflammation, they can mediate even thrombus formation, and they have also metabolic properties as well. So their baseline state or their normal state is very much important for normal vessel hemostasis. And that's how, because in its normal state, it is non-thrombogenic. It provides the non-thrombogenic blood tissue surface, and they can modulate vascular resistance, they can metabolize hormones, they regulate inflammation. So they basically control everything that goes around the blood vessels. So in their stable state, in their basal state, they maintain that normotensive laminar flow. But whenever there is a turbulent flow, either that of a damaged Lihonschlag or any sort of abnormality within the vascular wall that's independent of endothelial damage, then they are activated. And when they are activated, that's when you see that they release these cytokines and they promote complement fixation and everything, and that will result in a kind of prothrombogenic state, and also an increase in the permeability of the endothelial or the inner vascular wall itself. So that their activated state is very much important to maintain the response to injury. So endothelial dysfunction is basically refers to any alteration in the endothelial phenotype that's seen in different conditions, that's both pro-inflammatory and pro-thrombogenic. And the response can take a few minutes to a few hours to a few days. The other component, important to note, are the vascular smooth muscle cells. And they are responsible mainly for the vasoconstriction or the dilation that occurs in response to either a physiologic stimuli or a pharmacologic stimuli, like in the case of a sympathetic response or an exogenous sympathetic stimuli. And they can synthesize also extracellular matrix. The smooth muscle cells can deposit collagen, elastin, and other extracellular matrix fluids, proteoglycans, and they can also secrete growth factors and cytokines. So smooth muscle cells are stable cells. That means they don't normally divide unless there is a stimulus. Well, growth stimulus is normally stable, but if there is a stimulus, they can proliferate. So they are basically stable cells. If the stimulus is removed, they can become back to stable again. So for any type of endothelial injury, the response, the vascular wall response, tends to be stereotyped. Okay, so there is a one type of response for any type of vascular injury, intimal injury. And that basically involves the endothelium, like we said, the endothelium and the smooth muscle fibers. So whenever there is a damage to the endothelium, it breaks, it increases permeability, it allows cellular and also the complement elements within the vascular space, plasmaosteolytin, complement negation, allows it enters, allow yadergal with the intima indigaba. At the same time, the endothelium also releases cytokines that enables to activate stable phase atom growth factor release indiaragu smooth muscle cell and signal መስጠት ይችላል. So you have proliferating smooth muscle cells. So whenever there is the endothelium, permeability increases, and there is a migration of smooth muscle cells into the intima from the media. Okay, so they divide and they form extracellular matrix, and the response continues that way. So this is basically for any type of injury, this is the type of response you would expect in any vessel. So you call that a stereotypical response. The new intimal cells are those smooth muscle cells that have divided from the media and entered into the subendothelial connective tissue intimal space. And they are motile, they can move about. So stable cells are they are actively dividing cells, they can move about, they can divide, and they have the ability to synthesize those extracellular matrix components like the collagen, the elastin we've talked about. So basically, like in any sort of inflammatory reaction, at the end is stabilize የማድረግ effect እንዳለው ሁሉ the smooth muscle cells ፖይንታቸው ኢንጁሪው ሪሙቭ ከተደረገ በኋላ ሜትሪክሱን ሜንቴን የማድረግ እና ስታብላይዝ የማድረግ ነው ማለት ነው። So when we go to this is just a small revision so that you can understand today's lesson. We'll go to the main pathologies that we'll be discussing today. The first one is it's arteriosclerosis. So arteriosclerosis is a generic term, just like it sounds. It's an arterial sclerosis. That means any sort of hardening of the arteries. And the hardening of the arteries can happen due to different reasons. It can happen due to atherosclerosis, lipid accumulation. It can happen due to pressure, damage to the vessels and deposition of extracellular matrix, or even calcifications within the intimal wall. So it's more of a morphologic description, okay, physical description of arteriosclerosis or the hardening of the arteries. And its major manifestation are in these three ways. The first one is atherosclerosis, that is due to lipid deposition, medial calcific sclerosis, or it's known as Mockberg sclerosis, or arteriololosclerosis. So atherosclerosis we'll discuss. It depends. The hardening of the arteries, the differentiation between these two is mainly on where it occurs and what the pathophysiologic mechanism is. So atherosclerosis usually occurs in the larger arteries, okay? The bigger arteries, the muscular arteries, and arteries with elastic substance in them, like the aorta or the hepatic arteries or the big arteries. It does not happen in the arterioles, and the site where it occurs is within the intima. Medial calcific sclerosis or Mockberg sclerosis is associated with aging in people older than 50 years old when there is endothelial injury, and then there is that like repeated recurrent the stereotypical response. Sometimes these collagen fibers that are produced, or the collagen ECM that is deposited through time, it undergoes some sort of metaplastic response, and finally it becomes calcified. So in older people, particularly in the big arteries of the uterus or something, it's usually normal, particularly autopsy findings like calcifications on the muscular arteries in the medial wall magnet, but it's kind of common. So that is associated like the degenerative response. So it's not necessarily pathologic. Well, it is pathology because it is abnormal, but it doesn't really show, it doesn't end up being symptomatic in any way. So the other hardening is the arteriololosclerosis, which just like its name, this is hardening of the smaller arteries, right? The arterioles. And this usually specifically occurs in hypertensive patients, which we will get to discuss in our next lectures. Okay. So we have these three forms of hardening of the arteries. So atherosclerosis mainly involves the intima, right? The intimal layer. I'll show you how this happens. And the calcific sclerosis, Mockberg sclerosis, occurs in the media. This bluish substance you see here demonstrates calcifications. And we have arteriololosclerosis. This is an electron microscopy image of an arteriole, which has like a very amorphous substance deposition right in the wall here, which is usually a hyaline substance or sclerosed substance. We get to see that in our next lecture. So we'll begin with atherosclerosis. So atherosclerosis is a type of chronic inflammation that involves the intimal wall. So here we have the endothelial surfaces, and then here we have the yellowish part you see here is what we call the atherosclerotic plaque. This is it. and that is just beneath the endothelial layer. So that is the subendothelial intimal layer, right? So it is mainly intimal, and we have the internal elastic layer here, and we have the smooth muscle, and then we have the adventitia. So any sort of accumulation like this, fatty accumulation like this, is known as atherosclerosis, and it leads to the narrowing of the arteries. This is the lumen of the artery, right? So a certain part of the lumen is obstructed by these raised lesion here. So like we said, the big arteries, okay, the high muscular arteries not involving the arterioles is where atherosclerosis commonly occurs. We don't see atherosclerosis in the venous circulation. So at the end of atherosclerosis, I will ask you why the venous circulation does not support atherosclerosis, okay? So here we have, okay, this is the answer. So anyway, you have the pressure, usually high pressure zones in the aorta, in the large elastic arteries, and then you have the muscular arteries where you expect high pressure. That's where you see atherosclerosis. And as you go into the low pressure zones, you don't usually see atherosclerosis. Okay, let's move on. So it's atherosclerosis is one of the commonest cause of a coronary artery disease. So what are coronary arteries? Maybe text. What are coronary arteries? You can't respond using the text. Arteries of the heart. A little bit, Johannes. Arteries of the heart, the aorta is the artery of the heart, no? Yeah, arteries supplying the heart. Okay, very nice. Thank you for that. So it's one of the major, atherosclerosis is one of the major diseases of the coronary arteries, and it is the disease of the intima that leads to narrowing. So the risk factor for atherosclerosis, the most important ones, they can be classified as being modifiable and non-modifiable. So the non-modifiable risk factors are those risk factors that you can do nothing about. For example, age, sex, genetics, you cannot change. So they're called non-modifiable risk factors. So age is a risk factor for atherosclerosis, because it's kind of a progressive disease. So it's the injury due to atherosclerosis basically builds up over the years, and finally symptomatic disease becomes much more overt in an older age. So the higher the age of the patient, the higher the risk of atherosclerosis and its effects. Sex, so in younger individuals, it's mostly men. When I say younger, I don't mean like young people, but in younger individuals, males are more predominant. And females, particularly premenopausal females, reproductive age females, are pretty much protected. Estrogen is said to have some sort of a protective anti-lipid effect, so they tend to be protected. But after the menopausal stage, after the age of 50, then females are at higher risk of the formation of atherosclerotic plaques. Okay, the other is genetics. If you remember, there are diseases like familial hypercholesterolemia, where you have a high lipid content in the circulation or also within the tissues. That is a metabolic abnormality that is inherited. So that's sort of genetics. In any sort of metabolic abnormality that results in abnormal metabolism of the lipids can give rise to atherosclerosis. So then modifiable risk factors involve comorbid conditions that are more like lipid accumulation, like hypertension. Hypertension results in higher vascular injury, endothelial injury and al, just for the presence of pressure. Hypercholesterolemia, which is mostly due to lifestyle, dietary risks. And then diabetes, insulin resistance can also lead to defective metabolism of the fats as well. So cholesterol and lipid deposition can be high. And then also lifestyle, again, modifiable risk factors involve smoking. Smoking also highly contributes to endothelial injury because of the toxins that it has, and the lack of physical activity, obesity, all of these are more prone to hyperlipidemic states. So these are all risk factors for atherosclerosis. So other than this, we can consider inflammation as a risk factor for atherosclerosis associated with, again, chronic endothelial injury. But inflammation more or less predicts the risk of further complications of atherosclerosis. Okay, so if there's like continuous inflammation, you have a higher risk of occlusion of the arteries, not just plaque formation, but occlusion of the arteries and then progression of the disease. So just inflammation by itself is an independent risk factor for predicting prognosis of patients with atherosclerosis. So the other lipoprotein A, so the most lipids that are the culprits in the formation of atherosclerotic plaques are those cholesterols, okay, the low density lipoproteins, the high density lipoproteins. So low density lipoproteins are those that are deposited within the tissue. So a higher level of LDL usually predicts a higher risk of atherosclerotic formation. Lipoprotein A is a kind of special type of protein. So when lipids are transported in the circulation, they are usually associated with other protein fragments known as apoproteins. And the lipoprotein A is a particular type of lipoprotein that is associated with a particular type of dangerous apoprotein that cannot be metabolized and accumulates within the plasma. And that is by itself a risk factor for atherosclerosis. Stressful lifestyle, stress normally associated with high cortisol release, as you know. So high cortisol release means there is it increases blood cholesterol because it causes metabolic abnormality. It increases blood sugar. It increases triglycerides, and that fosters plaque formation. Metabolic syndrome has to do with something related with diabetes, but any metabolic syndrome that results in insulin resistance can lead to dyslipidemia and endothelial dysfunction. So CRP is a kind of acute phase reactant that basically measures the level of inflammation you have in the body. So it's a systemic sort of chemical that is measured to see if there is like an ongoing chronic inflammation going on. So by measuring the C-reactive protein alone, you can see if a person at risk of atherosclerosis or a person developing atherosclerosis and that atherosclerosis complicating into a much more severe cardiovascular disease. For example, atherosclerosis of the coronary heart eventually leads to ischemic heart disease. So by just measuring C-reactive protein, I can see if that person develops some sort of ischemic heart disease or myocardial infarction somewhere later in life. So Birmingham's study is a landmark study evaluating the risk factors for atherosclerosis. If you're interested, you can go study that. And it has this very beautiful graph where it predicts, or it's that the 10-year, even 20-year risk of cardiovascular diseases following for people who have atherosclerosis predisposition. So the relative risk is higher for those that have a C-reactive protein. This is the yellow bar here that has a higher C-reactive protein, more than 3 milligram per deciliter. So the more inflammation there is, the more risk of progression of atherosclerosis and the more risk of cardiovascular complications. So we'll just see the pathogenesis progressively. So the pathogenesis is that it is a chronic inflammation. We started that. It's a specific type of chronic inflammation, and it is a response to an injury. And that injury is mostly due to the endothelial dysfunction, and that's mostly due to hemodynamic disturbances or some form of hypercholesterolemia. Sorry. We'll go back to the slides later on. So prolonged exposure to potentially toxic agents. Okay, so we said it's a response to an injury. So that injury is mainly from either exogenous or endogenous substances, and the exogenous substances can be like mostly toxins from cigarette smoking, and endogenous substances can be those lipid substances, okay? So all of these can cause injury to the endothelium. And it is the way that the endothelium responds to this specific injury that results in the plaque formation. So whenever there is an injury, the endothelium is basically activated. Endothelial activation is mainly manifested through two main things. The first one is it becomes much more permeable, or it just becomes leaky, just like what you see in the case of acute inflammation. It becomes much more leaky. So if a person has high lipid state or hyperlipidemia state, the lipid this is the luminal end of the vessel. So in the lumen, loose lipoproteins can get access into the intimal space. So vascular permeability, and then you have the lipids within the circulation that we have, the high level of lipid molecules, the lipoproteins, that will get access into the intimal space. That is the first response to injury, to endothelial activation. So this is an electron microscope view of the intima. So you have the endothelium space here, this dark space here, and then you have the subendothelial connective tissue that is filled with these circle things, which are lipoproteins or the lipid substances or the large lipid molecules. So that is the first response to the injury. So the point of so this injury happens, and the next inflammatory response, the objective would be to remove these lipoproteins from these. They're not supposed to be here. They're either supposed to be circulating here or stored somewhere else. They're not supposed to be in the intimal space. So the objective of the inflammation is to remove this lipoprotein or lipid molecules from the intimal surface. That is the objective of the response. So in addition to when the endothelial cells are activated, as we discussed in Majameria, they have different functions, right? They release chemicals, they become, they can express adhesion molecules, okay? Endothelial activation, in addition to being permeable or leaky ከመሆን በተጨማሪ ደግሞ their surfaces become much more open to expression of the adhesion molecules, all right? They express adhesive molecules on their surfaces. So they can attach chronic inflammation mediated የሚያደርጉ ሴሎችን አታች ማድረግ ይችላሉ ማለት ነው። In this particular response, you would see a specific type of receptor that is expressed on the endothelial surfaces. It's known as the vascular adhesion molecule 1, and that is very specific in binding leukocytes, particularly monocytes, okay? The monocytes and a certain type of T lymphocytes. So the endothelial cells becomes leaky, it becomes permeable, and in order to remove that, you have a lot of adhesive molecules on the surfaces that attach leukocytes, like here. This is the cell, this is the endothelial surface, and this is the subendothelial tissue. And this is what you see on histology. So when monocytes get access into the tissues, what do you call them? What are tissue monocytes called? From your general pathology? Or from physiology, really? Anyone? Yeah, they're called histiocytes. That's a fancy name for macrophages. Yeah. They're called macrophages. So this is the intimal space. This is the histology of the intimal space, and you see macrophages here. And macrophages, what is their main function? Macrophages. What's their main function, or histiocytes? What is their mechanism of action in response to injury? Phagocytosis, yes, that is. They're kind of a chronic inflammatory things. So varilatory movement by the neutrophils or lymphocytes or any antigen-antibody reaction መውጣት የማይችሉ ፊክስድ የሆኑ ሰብስታንሶችን ፋጎሳይታይዝ አድርጎ ዲግሬድ ማድረግ ነው ሜን ፋንክሽናቸው ማለት ነው። And they can be kind of, they're, like I said, they're chronic inflammatory cells, so they can live a little bit longer. And they can multiply. That means they can activate, they can recruit more monocytes, they can activate more macrophages, and they're specialized for phagocytosis. But in addition to phagocytosis, when they're activated, they also tend to produce these reactive oxygen species. That is basically responsible for the toxicity of the phagocytized substance, the reactive oxygen species. So you have this thing, you have the endothelial surface more permeable, you have lipids going in, you have monocytes going into the intimal space. So you have now macrophages, and these macrophages are pretty much activated. So they are phagocytizing the lipid molecules around them. And they're also secreting reactive oxygen species. And these reactive oxygen species bind to the lipoprotein molecules. So when lipoprotein molecules are bound to reactive oxygen species, they tend to propagate the inflammation more. They tend to induce more inflammation to go on. Okay, so that is the critical point of chronic inflammation, in this case, oxidized lipids. Okay, so the macrophage interacts with the lipoprotein elements with a receptor known as the CD33. That's how it recognizes this CD36. That's how it recognizes the cell. So in addition to phagocytizing, when it is activated, it releases reactive oxygen species, but also expresses adhesion molecules on its surface that allows it to home to that particular intimal space. So it's staying there, it lives long, it's continuously phagocytizing and releasing reactive oxygen species, but also immobilizes there. So it can accumulate. So you have a lot of macrophages going in going in the intimal space, phagocytizing the lipoproteins, and then just homing there, staying there, stabilizing. So when a macrophage phagocytizes all of these lipid cells, so on the histology, it looks like this, okay? So that fat cell on histology looks like this, has this bubbly, clear cytoplasm. These are the macrophages here, macrophages. So just describing their morphology on histology, the macrophages that have phagocytized lipoproteins are known as foamy macrophages. This is just like a morphologic description. So in addition to the foamy macrophages, you can see sheets them here. You can also see other forms of inflammatory cells like lymphocytes here and here and here. So this is basically how the inflammatory response takes place. So the specialized the foamy cells are there, and then macrophages and also endothelial cells as well. They produce different cytokines that promote or facilitate the recruitment of smooth muscle cells from the media and also from precursor cells circulating within the circulation. So you have smooth muscle cells now proliferating, which is kind of promotes through the progression of the process here. So first you have the lipids. Macrophages, and the macrophages have basically engulfed the lipoproteins. Lipoproteins become oxidized, and this oxidization promotes more endothelial dysfunction and more endothelial cytokine release that promotes the more recruitment, or that propagates the recruitment of the macrophages and also recruitment of smooth muscle fibers from the media and from the circulating precursor cells. So the lesion, depending on its morphology and depending on the type of cells that are involved, it can be classified into these 6 types. So the first 4 types are mainly just indicating that level where the macrophages are there, and but with different degrees, the macrophages are there and they're engulfing lipoproteins. That's the first type 4. And type 5 is when it becomes much more stable with the coming of the smooth muscle cells, and the smooth muscle cells tend to deposit collagen fibers, so they tend to produce the extracellular matrix that supports the plaque lesion, or that lesion that we're talking about. And type 4 is a more complicated lesion that is associated with thrombus formation. When there is endothelial injury, like I said, on the baseline state, it is antithrombotic. The endothelial surface is antithrombotic, but when it is dysfunctional, it becomes prothrombotic. So you have a lot of thrombotic elements going on within the surface as well. So in addition to the plaque formed by the chronic inflammatory response, you would also see some level of thrombus formation. In that sort of complication is what we call a type 6 lesion. So fatty streaks are basically just spots on the surface of the endothelial surface. This is one of the large arteries of the abdomen, I think. These are the ostia, branchoቹ መጥተው የሚገቡበት ቦታ ነው። This is like a normal opening, but you see like yellowish spots that sometimes coalesce, and the fatty streaks basically represent those macrophages, lipid engulf አድርገው ኢንቲማ ውስጥ ቁጭ ያሉት macrophageዎችን ብቻ ነው represent የሚያደርጉት. And they are relatively small lesions, and they form flat surfaces, raised region, flat surfaces, and they are also small lesions. These are the foamy histiocytes that you see beneath this very thin layer of the endothelial surface. So morphologically, they are flat lesions. Here is also a histologic appearance of the foamy cells that we're talking about. So foamy cells have lipid in them, and lipid on histology is highlighted by a special stain known as oil red. And these, the lipid macrophages, they appear kind of bright red. So this is just a fatty streak and is not associated with that. Atherosclerotic plaque የምንለው is a much more progressed lesion. Okay, I think I have the picture. I don't have the picture. Oh, okay. More progress ያደረገ lesion ነው. So in addition to those sheets of macrophages that have engulfed the lipoprotein, you also have supportive extracellular matrix substances, including the smooth muscle proliferations. So it's much more solid, it's much more a stable lesion. So atherosclerotic plaque, and it also tends to be higher. You have proliferative substance, you have more substances in this, smooth muscle cells. So they tend to be raised lesions. They can vary from 0.3 centimeters to 1.5 centimeters in diameter, and they can also coalesce to form large masses. So here you see the bump things here. They represent atherosclerotic plaques just in the intima. Here is a much more complicated lesion. So in addition to the plaque formation, you have associated thrombus. That means the blood has clotted at that area and formed a much more complicated plaque, and it also seems to have ruptured. Again here, again here, again here. More complicated lesions. So this is the normal arterial wall, and this is the vascular occlusion that you would expect with the formation of the atherosclerotic plaque. So when you look at the anatomy of the atherosclerotic plaque, maybe I should have mentioned this before. The major component of the plaque is you have the macrophages, the foamy macrophages, lipidioato foamy macrophages አሏቸው. ከዛ in addition to the lipids inside the macrophages, you would also expect some lipids within the intimal surface, free float እያደረገ ያሉ lipids ሊኖሩ ይችላሉ. And then you have other lymphocytes, other inflammatory cells that promote the progression of this inflammatory response, and also these spindly things represent the smooth muscle cell proliferation that deposits the matrix, the background matrix here that stabilizes it. So one no point መጀመሪያ ላይ የጀመርነው response to injury ነው ብለናል አይደለ? ስለዚህ ኢንፍላሜሽኑ the objective of the inflammation is to contain the injury or the damage contain ማድረግ ነው. And the way it contains it is by walling it off. Basically inflammation progress እንዳያደርግ wall off ማድረግ ነው. ይሄንን የሚሰሩት ደግሞ are the smooth muscle cells that are proliferating, መጨረሻ ላይ ሪክሩት የሚደረጉት smooth muscle cells ናቸው. So they basically ወደ ሌላ ቦታ progress እንዳያደርግ completely wall off አድርገውታል. So this is the plaque that's formed. A stable plaque has ኤጆቹ ላይ this is known as the shoulder of the plaque. This is known as the apical side of the plaque, the shoulder, the apex, and also the cell basement membrane, the intima, the internal elastic lamina. ስለዚህ በእነዚህ ውስጥ completely walled off ይሆናል, and it is solid. እነዚህ are completely immobilized, and when progression, when there's no lipid coming in, and when the stimulus finally subsides, you have basically a walled off plaque that is a mass of these macrophages, and these macrophages, they live long, but at a certain point they die. So they die within the plaque here, and so it just becomes a mass of dead tissue, lipids, collagen, and so on. So after a while, it just becomes collagen tissue that just undergoes further degenerative changes unless there is a new endothelial injury that's coming in. So this is basically the anatomy of a stable plaque. That is minimum further complication yellow plaque ማለት ነው. So in this instant, just like this, completely fibrous cup, it's completely walled off, but in here you have the mass of the lipid tissue, the molecules themselves, and as times goes by, these particularly those released from dead macrophages become crystallized, they form cholesterol crystals. So even if this lesion itself, hardened lesion, it doesn't subside, but the process subsides, right? So here you have the lesion, a kind of hard lesion protruding into the lumen, obstructing it a certain degree, but not a lot. So unless there is like a recurrent lesion that kind of propagates these plaque, it's usually stable. That's why like it's a progressive disease in less than it just builds with more damage, more process, more chronic inflammation, and so on and so on. So the common areas where you would expect atherosclerotic plaques are the large arteries, particularly the lower abdominal aorta. You have the coronary arteries, the popliteal arteries, internal carotid arteries, and also the vessels in the cerebrum within the circle of Willis. Okay, so depending on, again, on the morphology, no stable plaque, no, basically stabilize but there is some vulnerable plaque where the formation of active injuries agents እስካለ ድረስ የሚቀጥል propagate የሚያደርጋለ ማለት ነው, and then the surface area ሊጨምር ይችላል, or it can further propagate with like ulceration of the endothelial surface, again thrombus formation, or even endothelial surface rupture ሊያደርግ ይችላል. And also they might be bleeding into the atherosclerotic plaque as well. So that those are vulnerable plaques. They have not formed these the extracellular matrix substance that helps stabilize the plaque. So acute plaque change are those changes that you expect like in the case of vulnerable plaques. And these can rupture, ulceration, or erosion of the luminal surface of the atheromatous plaques, and it can result a highly thrombogenic substance release yadergalu, so that means further thrombus formation. What's a thrombus? What's a thrombus? What do you understand when I say a thrombus? Anyone? Somebody copy pasted a macrophage response. Okay. Blood clot. ትንሽ አሻሽለው. Oh, maybe mailat. Oh, can I have to do this? Anyone want to try? Okay. Let's next we'll talk about thrombus, so we'll talk about it further. It can induce thrombus formation. Okay, it can activate the coagulation cascade, and such thrombi can partially or completely occlude the lumen and lead to ischemia. So this is basically the same, I think it's the same image that I've shared with you before. You have the atherosclerotic plaque and you have the complicated thrombus. Here is the normal the internal wall of a big artery. Okay, here we have another plaque as well. This is a very damaged blood vessel. Okay, so acute plaque changes that we have discussed before, there could be erosion, and then there could be thrombus formation. This is, like you said, blood clot within the lumen that obstructed that vessel. And here you see these crystal forms, they're called cholesterol crystals, and basically it has ruptured and completely occluded the luminal, the lumen of the vessel. This is a rupture. Here, hemorrhage into a plaque. This is the artery now, and you see a large hemorrhagic spaces here, and you know it is an atherosclerotic plaque because there is a massive cholesterol crystal formation here, and then it is bleeding. The surface is eroded, and you see bleeding into the intima. Here you have the smooth muscle, the media. So embolism. So whenever a plaque ruptures, it can discharge its debris macrophages or the extra cellular degenerative lipid components. All of them will be released into the bloodstream, and circulation it can go anywhere, and they can form microemboli that are composed of these plaque content. Another thing is that it can lead to aneurysm formation, and the thing is there will be we will discuss this your aneurysm part. But the way atherosclerosis initiates aneurysm mallet abnormal a dilatation of the vessel wall, and usually this dilatation happens as a result of a weakened wall. Okay, but I'm weakened on a degenerative yaragala. So all the layers atherosclerosis intima lesion, but in the case of intensive atherosclerosis that involves this like almost in a segment of tissue carla, okay, vascular wall carla, it needs to be supplied, maintained, supplied. So normally the media, okay, a part of the media it's supply, it's nutrient supply is through the vasopasora, but the inner side gets its nutrient supply from from the blood that circulates from on the luminal side. Okay, so as the wall becomes much more thickened, the demand, the oxygen and the nutrient demand also increases. So if that cannot be fulfilled for the entire medial wall or for the it cannot reach or the reach part kind of dies. So it becomes a weak wall, it becomes a thin wall, and whenever there is a high pressure circulation it dilates it, it pushes it. And when vascular wall elasticity or dagmo as a result of tissue ischemia and tissue infarction, then recoil maragachilum is all dilate and more pressure push dilate. So basically atherosclerosis aneurysm is through endothelial, to hypoxia of a thickened plaque. So media reach drugs a certain portion of the media reach drugs. That's what happens. So this is the abdominal aorta. As you can see, this is the big artery, the retroperitoneal abdominal aorta. It gives its branches. I think these are the renal arteries, and then a little bit distal to that, you can see it is kind of bulbous, right? So fairly dilated, and you can see its lower branches, which are, I think, the common iliacs. And when you open these open you will see this as dissection cloth, and you can see the rough surfaces with the very bumpy atherosclerotic plaques. Here, kind of yellowish plaques here as well. Again, this is much more serious. It's not just plaque dissection. So it's important to emphasize that atherosclerosis is slowly evolving lesion, but acute plaque changes acutely symptomatic ሊያደርጉ ይችላሉ ማለት ነው። and that phenomenon is known as the clinical horizon. Okay, so the preclinical phase is usually in the young age, and it is characterized by those morphologic lesions that we have discussed: the fatty streak, the flat lesions with just yellowish kind of change on the surface of the inner wall of the vessel, and then you have the fibrofatty plaque. Raised lesion occludes the lumen to a certain degree, and you have an advancing vulnerable plaque where you don't have the fibrous cap, and it is progressing with the occlusion of that lumen. In the clinical phase, it's usually due to acute complications. It could be due to aneurysmal rupture, and we can do whole bone ruptures or occlusion by the formation of a thrombus, or in the case of critical stenosis. So we call it critical stenosis if more than 70% of the luminal wall is occluded by the atherosclerotic plaque. And all of these clinical phases, as you can see, is due to that vulnerable plaque. So it's important to distinguish between these two. So here, atherosclerotic stenosis, you can see 40% here, kind of fibrous plaque, no, 60% open now. Here, kind of a circumferential plaque, and band side circumferential now. Also, the lumen is pretty open, 70% open now. And here you have a stage of critical stenosis where only 30% of the lumen can facilitate here. Again, even more critical, 10%. This is almost complete vascular occlusion, and then here you have 5%. So in these instances is where you would have complications like aneurysms or ischemia, hypoperfusion to any the tissue that this artery provides to. So in these three phases, then you might expect some level of symptomatic disease. Okay, either ischemic heart disease or angina. So the consequences of these critical stenosis or even acute plaque changes is these myocardial infarction. We'll see these pictures on our next lecture. These are these pale areas that you see is basically dead myocardial tissue. And here again, I think the anterior wall of the ventricle, one of the ventricle, so it's the cross section of the ventricle that has undergone normal muscle kind of like livery appearance in it, but this pale area indicates an infarct. Okay, that means a dead tissue as a result of tissue hypoperfusion. Here, you'd also expect lesions in the brain. Here you have ischemic infarcts, and you might even have liquefaction of the brain as a result of severe ischemia or occlusion of a major artery. And again, another peripheral arterial disease as a result of large this is what is this? Can anybody guess what this is? What do you call this? What is this? Anyone guess what this is? It's yes, Johannes, you are right. This is gangrene. So it's basically just unperfused perfusion gangrenous tissue, which is a kind of a special type of ischemic necrosis, as you know. Oh, how do I? So this is obstruction of flow as a result of either stenosis or an acute plaque change. So other consequences, sudden cardiac death, chronic ischemic heart disease, we'll see all of these again a little bit later on. And also ischemic encephalopathy, which is like a clinical syndrome that is characterized by this confusion transient ischemic attacks and all that stuff as a result of these small ischemias, particularly if you have microembolies from vulnerable atherosclerotic plaques that detach and go to the brain arteries. You can have like small infarctions within the brain that result in ischemic encephalopathy. So in small arteries, atherosclerosis usually does not happen in small arteries. What you would expect is probably an emboli from a larger plaque somewhere higher up in the arterial structure. But you can have these plaque or detached plaque substances, including lumens, and then compromising blood flow to the distal organs and then causing ischemic injury. And plaques can undergo disruption, precipitates, everything is a repetition here. Atheromas can be friable and they can shade emboli into the distal circulation. All right. So that's all about atherosclerosis. What you have to know about atherosclerosis is, I don't know, what is it? How does it occur? And then what are the major risk factors? And how does it progress? And what are the things that affect its progression? I can go actually. So our next on blood vessels is about aneurysms. So aneurysms, like what we have discussed, there are abnormally dilatation of the blood vessels, or even the cardiac chambers. Okay, aneurysms can also happen in the cardiac chambers, and they can be classified as being congenital or acquired dilatation. So you can see this is the abdominal aorta. No, this is the thoracic aorta that we have seen here, very dilated. So depending on the type of the lesion, you can classify aneurysm into being a true aneurysm or a false aneurysm. You call it a true aneurysm because there is an actual attenuation or thinned out wall. Okay, this is the normal vessel. And this is a true aneurysm because there is an actual damage to the wall, either to the intima, to the media, anything. Actual damage to the wall, you call that true aneurysm, so it becomes less compliant, and as pressure develops, it becomes dilated. So depending on also the morphology of the aneurysm, whether it's one-sided, two-sided, or what kind of dilatation it gives you, you can classify it as being circular and fusiform. That's purely morphologic classification. You call it false aneurysm when there is no thinning out of the wall, but there is a defect somewhere in the wall, and there is extravasation of the blood into the surface, but the blood is not spilled into the outside. Instead, it's kind of walled off by an extravascular connective tissue. There are instances where this happens. There is a blood extravasating, and then but not spilling over to the adjacent tissues and walled off by a fibrous cap. This is called a kind of pustulating hematoma. It's a kind of hematoma, pustulating hematoma, and it's when you look at the vessel grossly, it looks like it is dilated, but it's not dilated. The vessel also, it's not dilated. Dilated is the collection of the hematoma itself. So that is a kind of false aneurysm that you would expect. So aneurysms can be classified depending on what caused them. So they can be atherosclerotic, as I'm discussing that due to ischemia of a big wall that needs to be supplied, or it can be syphilitic, that is due to the damage of the vessels in the adventitia. That it could result in aneurysms. You can have congenital aneurysms, ventricular aneurysms that follow a transmural MI. So I will tell you how that occurs. Here, again, the aorta dilated. What is this? What do you think is happening here? What is this? The arrow here. here. A little bit more, Lena. It's a tear, but dissection is a kind of form of a tear, but this, you cannot call this dissection because why can't you call this dissection? Okay, so this is more of a tear, the entire wall, dissection. It has entire wall, including the adventitia, total. So this is more of a rupture, okay, aneurysmal rupture here. And when you open it up, you can see the thrombus, a massive thrombus here, and probably also has some level of dissection, as you mentioned here. Dissection, aortic dissection mainly. There is a defect here, and hemorrhage enters into within the wall, but it doesn't pass beyond that particular vascular wall. So it splits the walls apart and just progresses downwards, downstream into the vessel wall. That's what you call dissection. If there is a defect here, defect called that has ruptured. Dissection, rupture, and dissection. So this is what we were saying about the aneurysm of the cardiac muscle. Here, you see. This is probably a massive infarct in one of the wall here. You see the normal muscle, but also then you see this is a fibrotic lesion here, even adhesions that demonstrates a chronic infarct. Okay, there is some sort of tissue loss here, and if there is a tissue loss here, compliant muscle wall whenever there is under pressure ሲመጣ ሲገፋው wall እየሞተ ያለ wall ነው pressure ሲመጣ ሲገፋው ዳይሌት እያደረገ የሄደ ሞል ነው ማለት ነው። ሶ በጣም ኮምፕላያንት ስላልሆነ ደግሞ እዚህ ውስጥ የገባ ሄሞሬጅ ዩዥዋሊ ዳዝንት ጎ አውት። ሶ ስታሲስ ይፈጥራል። ስታሲስ ካለ ደግሞ that's a good environment for thrombus formation። ስለዚህ this it makes it much more prone for a thrombus formation። እንደገና ሌላ ኤምአይ ደግሞ ይሄ ሰውዬ ኦከር ካደረገ particularly በዚህ ቪሲኒቲ ምናምን አካባቢ ከሆነ rupture ሊያመጣ ይችላል ማለት ነው። If there is cardiac wall rupture, then that's almost instant death, right? Because there will be massive hemorrhage. So aneurysms are most important when they involve the aorta because it is catastrophic, because the aorta, but a chunk of the blood goes to the upper part and to the lower part carrying the so you need to look out for them. And the commonest is also the abdominal aortic aneurysm that we see. The two most important causes of aortic aneurysms are atherosclerosis, and also hypertension. And other causes that weaken the wall and lead to aneurysms include trauma, congenital defects. These are like berry aneurysms. Berry aneurysms are basically these saccular aneurysms that you usually see in the brain. So they can be congenital and they can also be acquired. They can follow hypertension or atherosclerosis. So we call them berry for mostly their morphologic description. Infections, they're called mycotic aneurysms. It can be due to bacteria, it can be due to virus, or it can be fungal infection. So the inoculation of these organisms in the aorta can result in a sort of inflammation and the destruction of the wall, resulting in its weakening and then progressive dilatation. Or syphilis. Syphilis also has a particular type of aneurysm. We'll discuss it a little bit later on. So they can also be caused by systemic diseases, vasculitides. Vasculitides are those diseases that are mostly mediated by these autoimmune problems. Okay, so any sort of like antigen antibody complexes forming within the endothelial wall can result in chronic inflammation and result in weakening of the wall and dilatation. So the commonest aneurysm that we need to watch out for is the abdominal aortic aneurysm. That is the common site because this is a high pressure zone, and it's also because it is the common area where you would expect atherosclerotic plaques, which are major risk factors for the formation of aneurysms. So atherosclerotic aneurysm, here you see this button opened up in space, and then you have the fatty streak areas here, and it leads to aneurysm. So this is what I have discussed for you before on how atherosclerosis causes aneurysms. It is basically because the thickness of the atherosclerotic plates will not allow for the adequate perfusion of the media. Okay, certain part of the media perfused በደንብ perfused እንዳይሆን ያደርጋል ማለት ነው, and that leads to days, and that leads to the thinned out wall in the formation of aneurysms. So in some cases, hereditary defects, if you remember the Marfan disease, where there is abnormal cross-linkage of fibrin in the formation of collagen, so there's a strong yellow collagen forming as part of the extracellular membrane material. The weak extracellular membrane material, it's not really resistant to any sort of pressure or any sort of demand. So it's more likely to be weak, and it's more likely to result in aneurysms. So we have three different variants called inflammatory, depending on basically the morphologic appearance of abdominal aorta. Inflammatory, you would see a lot of, that means on morphology, you would see lymphoplasmacytic infiltrates, and it can follow different stimuli. Immunoglobulin or IgG related disease, you would see some a response to a particular antigen antibody reaction, and you call it mycotic when you have lodged microorganisms within the vascular wall. So depending on the morphology of the lesion, whether it has like a specific antigen antibody reaction or just simple lymphoplasmacytic response, or if you can identify the actual microorganism, you can classify them based on their morphology like this. Atherosclerotic aneurysms occur most frequently in the abdominal aorta, abdominal aortic aneurysm, but the common iliac arteries, that's the branch of the abdominal aorta, as you know, and the descending parts of the thoracic aorta can also be involved. A clinical consequence could be a rupture, but dilated, but weak hono. If there is like a massive, for example, hypertensive patients, if there is like an acute rise in blood pressure, but high pressure, it can rupture it and can result in fatal hemorrhage because, again, it carries a chunk or a volume of blood that is significant. And it can result as an obstruction of a branch vessel, resulting in a downstream ischemic injury. These are abdominal aorta renal artery, or embolism. So as you know, but dilated vessel wall is much more prone to stasis, and it's much more prone to the formation of thrombus. And once thrombus detaches, it influences and travels elsewhere. And it can impinge on an adjacent structure, compress the ureter, or erosion of the vertebrae, and do that. And it can present in the form of an abdominal mass, a pulsating abdominal mass, some sort of cystic tumor. So these are very serious complications. So Thoracic aortic aneurysm is most frequently caused by hypertension, and this is just an aneurysm that occurs in the thoracic artery. As you know, the thoracic artery is the aortic artery, is the one that leaves the heart, the left side of the heart, and as it goes there, it forms the arc, and then it forms the ascending, the arc, and then you have the descending thoracic artery. So regardless of what etiology it has, most commonly it's, like I said, hypertension, but it can cause like compression adjacent የሆኑ structureዎችን respiratory difficulty ሊያመጣ ይችላል. It can have difficulty of swallowing because it can compress the esophagus. And then you can have persistent cough due to irritation of the recurrent we see how that works in narrowing of the coronary ostia. So it leads to valvular insufficiency, particularly if the aneurysm occurs just as it's leaving the left ventricle. Just aortic root line, aortic root line, but I'm dilated ከሆነ valvoቹ መዘጋት አይችሉም because there is a space, significant space between them ስላለ. So they might result in valvular insufficiency or regurgitant lesions. Regurgitant lesions ደግሞ volume overload ያመጣሉ. So they might result in a cardiac disease. And as you know, coronaries ከየት ነው የሚነሱት? Coronary arteries ከየት ነው የሚነሱት? Somewhere around the root of the aorta, right? The major coronary arteries የሚነሱት እዛው አካባቢ ነው። So dilatation ስላለ እሱ ጋር obstruct ሊያደርጓቸው ይችላሉ, resulting in ischemic disease of the heart. And of course, aortic rupture can occur if there is significant thinning of the wall. So a particular type of aneurysm, known as the syphilitic aneurysm, which is characterized by obliterative endarteritis. So what we mean by obliterative endarteritis is a kind of inflammation that kind of completely obliterates or occludes the lumen of small vessels. So this is a pathologic process that involves the very small vessels. Okay, not the tough muscular levels, but the very small vessels. So syphilis mainly affects the vessel wall of, or the response to the syphilis mainly involves the vessel wall of, have a picture. So these are the, so we have discussed about the vasa vasorum. These are the vessels that supply the vessels, right? And they mainly supply part of the muscular wall or the media of the vessel. And they're very important. So syphilitic lesions, particularly tertiary syphilis, result in the inflammatory process known as the obliterative endarteritis, which involves plasma cells and the spirochetes themselves and the plasma cell response, and that leads to occlusion, okay, the obliteration of the vessels. So if they are እነዚህ በሙሉ obliterated vessels which በሙሉ obliterated ከሆኑ, then the area that is supplied by them will be weakened and then result in aneurysms. So leading to aneurysmal dilatation of the aorta and the aortic annulus. The aortic annulus is the region of the aortic root, as you know, and it can become dilated, valvular insufficiency, massive volume overload, hypertrophy of the left ventricle, and then this hypertrophy as a result of syphilitic aneurysm is known as cord bovium or cow's heart, because massive overload. So this is basically a summary of what we discussed between what causes and what is the morphologic appearance of abdominal aortic aneurysm and the thoracic aortic aneurysm. So thoracic aortic aneurysm እዚህ ጫፉ ላይ ገና ሲወጣ አፕል ሊያደርግ ይችላል፣ ascending part ላይ አፕል ሊያደርግ ይችላል, and then descending part ላይ ደግሞ አፕል ሊያደርግ ይችላል. So as a majority of them occur in the ascending part of the thoracic aorta, and 80% in the abdominal abdominal aortic aorta occurs distally, just below the renal artery. So infrarenal artery, not just 80% occur. So these sites are important to look out for. We're evaluating for aortic aneurysm. So the next is what we call the aortic dissection, or it's known as dissecting hematoma. So whenever there is like a dissection, or this, when there is like a compromise with the endothelium, and then blood gets access without actually rupturing the whole of the wall, then blood can split between the laminar planes of the media and cause what's known as the dissection. And it often ends up rupturing outwards. That causes eventually massive hemorrhage. So here is the internal wall, and you can see the tear here. But you can see posteriorly the opposite aspect of the wall, which tends to be intact. So here, an intimal tear, and the dissection here. This is a very nice histology. Here, this is the endothelial surface, and it has ruptured, and then blood has gotten access between the medial wall, and then you can appreciate blood between these two medial walls. Again, here, a massive tear and a clot, right? Hemorrhage, clot, any other lesion, ከነዚህ ሁለቱ ቲሮች እና ውስጡ ካለው chronic clot ውጪ የምታያቸው ደግሞ ሌሎች ሊሽኖች አሉ, like this, which is the atherosclerotic plaques. Very rough inner surface of a vessel. It shouldn't look like this. በጣም damaged ነው. Again, hemorrhage between the two muscle planes. It is first the inner aspect of it, and this is the outer aspect of it, and you can appreciate the tissue here, again, splitting the muscle wall. Aortic dissection occurs principally in two epidemiologic groups. You have men which have comorbid condition, usually with hypertension, or you have a younger patients with connective tissue abnormalities that predisposes for the defects to begin with in the first place, like in the case of Marfan syndrome. So younger patients more likely to be associated with genetic conditions, older patients most likely to be associated with chronic comorbid conditions like hypertension. Clinical course, the risk and the seriousness of the complication will depend upon the aorta that is affected. So dissection involving the aorta from the aortic valve tends to be much more serious. And they can be classified in two types, as proximal lesions and distal lesions. So the proximal lesions are involving these two types, or the type A የሚባሉ. These are the lesions affecting the proximal aorta, involved የሚያደርጉት ናቸው። እዚሁ ascending ኦቫ ሊቀር ይችላል, or ደግሞ ፕሮግረስ ሊያደርግ ይችላል. Or the lesions that involve distally below the subclavian artery. Okay, here are called, here is the dissection, that are called distal lesions. So the more proximal ones are usually much more severe, because that's where you'd expect massive amount of hemorrhage to come through. So the classic clinical symptoms of aortic dissection is that it is very painful, sudden onset of excruciating pain, particularly in the background of a person who already has a risk factor. Then that is something that you should expect. And also possible ischemia is one of your differential diagnoses for this excruciating pain. And the pain typically radiates to the back, particularly when it progresses going down to involve more distal aspects of the aorta. So the most common cause of this is, as you can imagine, is rupture of the dissection outwards to any of the three body cavities. So pericardial, it is much more closer to the, it's a proximal type kohona, either pericardial or pleural honal, with a touch of abdominal aorta, like you would expect the massive hemorrhage to end up in the peritoneal space. So common clinical manifestations include cardiac tamponade. Cardiac tamponade is basically when there is a massive fluid accumulation within the pericardial space between visceral and the peritoneal pleura. There is a space associated with unhemorrhagic gapto. But I'm expanding it compresses the ventricular wall. A kind of mechanical obstruction into the heart muscles. So cardiac tamponade is a major manifestation. Aortic insufficiency is also a major manifestation because now there is dissection going on. The aorta will not be able to accept the pressure that is pushed from the left ventricle, and then also can result in some sort of a backflow, or a backflow into the left ventricle and result in some sort of overload and congestive symptoms. You might have myocardial infarction as a result of involvement of the branching involvement of the aorta at the branching of the coronary arteries, or even as a result of reduced cardiac output, suddenly on a reduced cardiac output due to the dissection. And you can also appreciate extension of the dissection into the great arteries. So the great arteries, what are the great arteries? What are these arteries? Name the great arteries. You have 5 seconds. These arteries. 5 seconds. Really? What are the great arteries? Middle branches, common carotid, the brachiocephalic, common carotid. What is SCV? Oh, the vena cava? No, another branch. Yes, there is the common carotid here. The brachiocephalic trunk, the common carotid. What about this? The subclavian. Yes. So, in addition to, in addition to following the track of the aorta itself, it can also extend into the branches. The dissection can extend into the branches as well. Okay. All right. So this is about the blood vessels. If you have any questions, I will wait for you to pose them. If not, we're going to take a 10-minute break and we'll come back with the ischemic heart diseases. Ischemic heart diseases. The heart and some of the common pathologies we would encounter. So heart disease, the general mechanism of a heart disease can be classified in mainly these 6 principal ways. The first one is the failure of the pump. So what is the function of the heart? Short answer on the chat box. What's the function of the heart? If I ask you a very simple question like this, how would you respond? What's the function of the heart? Yeah, pump blood. Exactly, that's what it is. So a pump failure. And what's the pump, really? When you say pump? What functions are you talking about? you're basically talking about two pump functions. What are they called? Okay, Leila? Leila? What are the basic pump functions of the heart? ወዴት ነው ፓምፕ የሚያደርገው ማለት ነው? Exactly. So the systemic and the pulmonary. So what is systemic saying? What is systemic and the pulmonary? So here it is. So when it pumps into either the systemic or the pulmonary, it's basically a closed loop አይደለ? አንዴ ያወጣውን ደግሞ መመለስ አለበት አይደለ? ሰርኩሌት ነው የሚያደርገው አይደል? ሲያወጣው either into the systemic or the circulation, it's basically a systolic function አይደል? ይመልሰው ደግሞ መልሶ ፊል ሲያደርግ ደግሞ that's basically a diastolic function. Yes? So any sort of abnormality in these two functions, which is usually due to the heart muscle problems, okay? But weakened heart muscle cannot squeeze as well. ስለዚህ cardiac output ይቀንሳል ከዛ right ventricle pump የሚያደርገው ይቀንሳል depending on which side is involved. But if it is also በጣም stiff ከሆነ ደግሞ የሚመጣውንም blood accommodate ማድረግ አይችልም። ስለዚህ ሪላክስ አያደርግም። ስለዚህ there would be a kind of stiff heart muscle which results in a diastolic pump failure, and then a systolic pump failure ደግሞ inability for it to push it out. Diastolic accept ለማድረግ ነው፣ systolic ደግሞ push out ለማድረግ fail በሚያደርግበት ጊዜ these are the two distinct pump abnormalities we expect. Another abnormality in the heart that we see is obstruction to flow. So it could be due to atherosclerosis ሊሆን ይችላል or any other mechanical obstruction ሊሆን ይችላል, congenital anomaly like coarctation of the aorta, this congenital ሊሆን narrowing of the aorta ሊሆን ይችላል. So any sort of obstruction of blood flow, including valvular stenotic lesions. Valvular stenotic lesions are also obstructive blood flow, can result in a cardiovascular abnormality. That's another mechanism. Another mechanism is regurgitant flow. So if there is like a backward flow of blood where you expect it to be pushed outside as a result of valvular insufficiency, or even in the case of diagonal aneurysms and the same mechanism, they result in a regurgitant flow. Regurgitant flow, as you know, results in a volume overload and finally abnormality. Another abnormality is the shunt flow. So the cardiac, the system, the cardiac system, it's a closed loop. Okay, so it shouldn't mix at any point unless it is like a neonatal circulation. At any point line mix oxygenated blood and deoxygenated blood mix but if there is like a defect in one of the system abnormalities, like in the case of ventricular septal defects, septum defects, congenital anomaly, you would expect some sort of mixing of blood, and that is a shunted, and that's when you call a shunted flow. And then disorders of cardiac conduction. This is the impulses. Where is the cardiac impulse generated? The SA node. Where is the SA node? ከዛ የት ይሄዳል? እስቲ SA node ላይ የመጡት ወዴት ይሄዳሉ? ምን ውስጥ ይገባሉ? Impulses. By the way, what's the SA node structurally? Yeah, it's found in the right atria. Very nice. Structurally, ምንድነው SA node? What is it? Is it a nerve? Is it a vessel? Yeah, it's a muscle tissue, but that is a special kind of muscle tissue that can transmit impulses, electrical ሲግናሎችን የሚያስኬድ ነው ማለት ነው። So ኤስኤ ኒድ ከኤስኤ ኖድ በኋላ ማን አለ? AV node. AV node, where is AV node? Internal bundles, internodal bundles. I'm not sure what you're saying. AC node, AV bundle, right and left, and then into the Purkinje fibers. Thank you, Bemit, for that comprehensive answer. So any sort of abnormality within the conduction system, it could be due to like a structural abnormality in the myocyte ሊሆን or due to some metabolic abnormalities that interfere with the transmission of the conduct, the transmission of the impulses ሊሆን ይችላል, hormonal, anything. Arrhythmia የሚያመጡ ነገሮች በሙሉ is also one mechanism of cardiovascular pathology. Okay, let's move on. And the other thing is a rupture of the heart or a major vessel, particularly aneurysm, is also one of the mechanisms for a cardiovascular abnormality. So heart failure is basically means in the definition of heart failure is that it cannot supply the demand that from the tissues. Okay, that's basically what heart failure means. The heart, because of different mechanisms, in any one of these mechanisms, it cannot manage to supply the peripheral demand. And it's the common endpoint for many cardiac diseases. If any cardiac disease ended up to the level of heart failure, which usually ends up being congestive, we'll see why it's called congestive. If it ends up being a congestive heart failure, then it usually has a very poor prognosis. So I'm not exactly sure about the statistics in our country, but in what we know, like 50% of the cases, only 50% of the cases have a 5-year survival rate, half of them. So we expect almost half of the patients to die within 5 years. That's what it means. So congestive heart failure is a kind of, it comes and goes. It's a recurrent thing. Sometimes it's improved and sometimes it comes back, but it's something that cannot be like absolutely improved because the heart undergoes a lot of compensatory mechanisms before it fails. When it actually fails, it's usually difficult to bring it back. So it ends up having a very poor prognosis, the heart failure. So this is what I'm saying. The definition of a heart failure is that the heart cannot generate sufficient output to meet the metabolic demand of the tissues, or it can only do so at a higher than normal filling pressures in the case of compensated failure. So heart failure is usually, you can look at any of the mechanisms, but it's usually a consequence of the deterioration of the myocardial contractile function, which is the systolic dysfunction that can occur in the form of ischemic injury or in the case of either a pressure or volume overload, or its inability to expand and fill sufficiently, which is called a diastolic dysfunction, like in the case of massive left ventricular hypertrophy, but massive almost restrict ያደርገዋል. So diastolic dysfunction ያመጣል. Myocardial fibrosis, it cannot expand, okay, that በጣም fibrosis ካለ fibrous tissue elastic አይደለም, ስለዚህ it cannot expand, so filling in interferal, constrictive pericarditis, which is like a mass-like compression from the periphery of the heart, which kind of also decreases the ability of the heart to relax while during the filling phase. So any sort of systolic dysfunction and diastolic dysfunction, usually inherent to the heart itself, is the one that leads to heart failure in most instances. But any one of the conditions that I've discussed before can result in heart failure. It can also result in a high output failure. A high output failure is a kind of heart failure that doesn't occur because of some sort of abnormality within the heart. The heart is usually normal, but the cardiac load, the workload on the heart is massively increased within a very short period of time. For example, in thyrotoxic patients, where you have the thyroid hormone being released excessively and then elevating the basal metabolic rate, that means increasing the peripheral demand of almost every cell, and also resulting in peripheral massive peripheral vasodilatation. The heart is required to circulate large volume of blood through its system, and it's also and because of the thyroid hormones also increase the activity of the heart, the workload on the heart usually increases. So it's not structurally abnormal, and functionally it's not abnormal, but the workload is just intense and it's very high. And because of this reason, if it fails as a result of that, that is known as a high output failure. Particularly if that's insinuating agents, for example, excessive የሆነ thyroid hormone ወዲያው withdraw እስካልተደረገ or correct እስካልተደረገ ድረስ, it leads to a high output failure. Anemia is also one of the causes of a high output failure. Increased demand. Okay, severe anemia, but increased demand ካለ በጣም serious የሆነ systemic abnormality ስለሆነ ማለት ነው። So whatever the cause of congestive heart failure, CHF ማለት congestive heart failure ነው, is characterized by decreased የሆነ cardiac output, the supply ይቀንሳል, and the tissue perfusion, which is called a forward failure. And of course, pooling of blood in the venous system, which is known as the backward failure. So the failing heart has an increase in the endodiastolic ventricular volume. What is the endodiastolic ventricular volume? What's the endodiastolic ventricular volume? Yeah, the volume of the blood, that's fine. And after filling of the ventricle, anybody can guess why a failing heart ends up with this? Very short response. That's correct. Very nice. Why do you think there will be an increase in the endodiastolic ventricular volume? Yes, because the amount of blood that's going out is less. So a lot of it is retained back. It goes it stays within the ventricles. So endodiastolic volume, just the starting principle has kind of puts pressure on the ventricles itself, results in increased endodiastolic pressures. And endodiastolic pressures eventually results in an elevated venous pressure. What does that mean? How does it result in elevated venous pressure? There will be congestion within the venous circulation because there is a lot of backflow. Endodiastolic volume መውጣት አይችልም. So within the ventricles, there is a lot of backflow within the pulmonary circulation and then within the venous system as well. So there is a congestion of the venous circulation, and that is known as a backward failure. So forward failure is the inability of the heart to pump oxygenated blood outside, or the system out into the systemic circulation, whereas backward failure is the inability of the heart to feel, or also the pressures going back into the pulmonary circulation outside of the heart. That's what we call the backward failure. So the compensatory mechanisms in cardiovascular system. The first one is the Frank-Starling mechanism, so the normal heart. What's the Frank-Starling law? Can anybody revise for us what's Frank-Starling law states? Just a simple formula, maybe. Yep. The higher the ventricular stage, the higher the cardiac output, or the higher the stroke volume. So let's see, the first response that you have is increase the preload, and it does that by undergoing different responses, like the activation of the renin-angiotensin-aldosterone system, where it tries to maintain the pressure within the vessels by release of antidiuretic peptide and all that stuff. But in the case of, but that is limited, yeah. The response in the Starling mechanism is very much limited after a certain point. The function of the heart compensate ካደረገ በኋላ ግን unless one stimulus or one problem is resolved እስካልሆነ ድረስ the function of the heart starts to decline. So there are two types of hemodynamic overload that lead to heart failure. We have the pressure overload, and we have the volume overload. So what's the difference between talking about pressures? Well, when you're talking about afterload and preload, anyone? Yeah, so whenever there is a pressure overload, the response that is increased afterload, the response is concentric hypertrophy. The major two types of concentric hypertrophy, and when there is an increased preload, that is filling. Okay, filling to accept more blood, it undergoes eccentric hypertrophy. But the difference between concentric hypertrophy and eccentric hypertrophy, both of them are compensatory mechanisms. Concentric hypertrophy aims to increase the cross-sectional area so that the pressure, okay, the elevated pressure within the ventricles can be resisted, whereas eccentric hypertrophy tend to increase the length of the sacromeres so that it can dilate and accommodate increased preload አይደለ feeling the volume overload and accommodate ማድረግ እንዲችል የሚያደርግ ነው ማለት ነው. So that is the response between these two. So increased የሆነ pressure results in በደንብ push ማድረግ ወደሚችል type of hypertrophy, kind of parallelly, arranged sacromeres, whereas eccentric hypertrophy ደግሞ more dilatation or accommodative የሚሆን ነገር ይለወጣል ማለት ነው. So in the case of concentric hypertrophy, it's also associated with a certain degree of fibrosis. So you would expect some level of abnormality with the contraction. Can normal hypertrophy ካላደረገ cardiac muscle ጋር ስታነጻጽሩት ትንሽ abnormality expect ልታደርጉ ትችላላችሁ, but still it is compensatory and it helps with resisting the pressure in the ventricles. So you would expect this type of pressure hypertrophy in the case of hypertension. Hypertension themselves, systemic hypertension. Systemic hypertension ማለት the left ventricle has to push against a high pressure አይደለ in the peripheral circulation ላይ ያለ high pressure against pump ማድረግ አለበት ማለት ነው. So in order to increase that, in order to compensate for that pressure, it undergoes hypertrophy, and that is the kind of hypertrophy you would expect in hypertension. Also, same mechanism, aortic stenosis. Stenotic lesions, as you know, is those lesions, the valvular lesions, when the valves fail to open. So they have like a very narrowing of the aortic stenosis. So you need to have a high amount of pressure to move blood out into the systemic circulation. That also results in an increased afterload and requires hypertrophic changes like this. With eccentric hypertrophy is usually accompanying ECM degeneration. Zika fibrosis no expecting taragut, but this is some structural abnormality you would see in ECM degeneration. Aortic or any regurgitant lesions will result in volume overload. As you know, during the systole phase, you have blood being pumped into either the systemic circulation or the right ventricle pumping it into the pulmonary circulation. But if you have open valves during a systole period, then when the atria or when the left atria or when the right atria contracts during the systolic period, can dump certain amount of volume within the ventricles, resulting in high volume in the ventricles even after the systolic phase has ended. So any sort of regurgitant lesions result in volume overload. Myocardial infarcts can result in volume overload, again, due to insufficiency, but mostly valvular insufficiency as a result of endocardial damage or myocardial damage. Ventricular septal defects, because there is shunting of blood, mixing of blood. We have a large volume expected within the ventricles. Also during the systole phase, you would expect some volume to remain within the ventricles, and so on. So compensatory hypertrophy, it comes at a cost. So the larger the heart muscle, then the larger the need of the oxygen demand or the oxygen requirement of this hypertrophic myocardium are amplified, and that makes it much more vulnerable to ischemic injury. So the difference between left side heart failure and right side heart failure. So heart failure affects predominantly the left or the right side of the heart, or it can involve both sides of the heart. So left ventricular failure can happen volume overload, regurgitant valve, particularly mitral regurgitation, can result in left ventricular failure. Pressure overload, systemic hypertension, valve mechanism, or outflow obstruction due to aortic stenosis can result in left ventricular failure. And also the loss of the muscles as a result of ischemia can result in left ventricular failure. Restricted feeling, pericardial effusions, cardiomyopathy, we'll see later on, tachyarrhythmias can result in left ventricular failure. So in the left ventricular failures, the pressure in the pulmonary veins are transmitted retrograde to the capillaries and the arteries. You would expect pulmonary congestion and edema. You will have heavy, wet lungs because it's not pumping out into the systemic circulation. It's going back through the pulmonary circulation, and you would have congestion within the pulmonary circulation. So that is what we call left side congestive heart failure. So when you look at the pulmonary circulation, you would see a lot of macrophages. This is the interstitial space on the pulmonary circulation. These are the alveolar spaces here, and this is the interstitial spaces, and you will see these heart failure cells. These heart failure cells are basically macrophages that have engulfed the excessive fluid, extracellular fluid within the pulmonary parenchyma. So በጣም ብዙ fluid ስለሚኖር those will be engulfed, and you would see these cells, heart failure cells. Here again, left-sided heart failure. It's characterized by this manifestation, paroxysmal nocturnal dyspnea. This is a particular type of shortness of breath that affects patients late at night, and they suddenly rise up from bed and they have these a kind of suffocation and they need air. That's one manifestation of a pulmonary congestion or elevated pulmonary capillary pressure. Restlessness, mostly due to hypoxia, confusion, also hypoxia. They will have orthopnea, the shortness of breath that is and that has a relationship with the position. Tachycardia is part of the compensatory mechanism. The heart rate is usually elevated. Exertional dyspnea, that means when there is a higher demand for oxygen, then the heart needs to work more, and that results in shortness of breath. That means more congestion and more shortness of breath. Fatigue, again, has to do with the hypoxia and with the less capillary perfusion of the peripheral tissues. Cyanosis is blowing is also due to that. So the right-sided heart failure is usually a consequence of the left-sided heart failure, since any pressure increase in the pulmonary circulation reflects back into the right side of the heart, okay, mostly as a kind of a pressure overload. Yes, so any but pressure in the pulmonary circulation build ካደረገ the pulmonary vasculature undergoes responses ይህንን resist ለማድረግ vasoconstriction ያመጣሉ ፕሬሸሩን normally ትልቅ ያደርገዋል ማለት ነው። So the right side of the heart has to work against high pressure within the pulmonary circulation, and that results in so the high pressure within the pulmonary, the right ventricle has to work against the high pulmonary pressure, and that results like progressively right side of the heart hypertrophy ያደርጋል hypertrophy ካደረገ በኋላም ደግሞ eventually fails. Isolated የሆነ right side heart failure is very rare, it's infrequent, and it usually has to do with some intrinsic problems within the pulmonary circulation. Okay, right side congestion ጋር ምንም የማያገናቸው diseases like ለምሳሌ fibrosis diseases or vascular abnormalities within the pulmonary vasculature, like interstitial lung diseases, and they make the pulmonary parenchyma less compliant for the right ventricle to work with. So it's working against high pressure, and that results in left-sided heart failure. So when it is isolated, it's known as cor pulmonale. Okay, so in the case of congestion, any sort of congestion that goes back into the pulmonary congestion, and also back to the peripheral parenchymas, again including in the venous pressures, can result in hepatomegaly, congestion in the liver as well. As you know, the inferior vena cava is kind of a direct branch. The hepatic vein is a direct branch from the inferior vena cava. So if there is a high congestion overload within the venous circulation, you would also appreciate it within the liver parenchyma as well. So you would see a lot of congestion within the liver sinusoids as well. So the appearance is called a nutmeg liver. This is basically a cross section of the በጣም edematous የሆነው area appears pale like this, and the normal እንደዚህ pinkish ነገር ይሆናል ማለት ነውና nutmeg መሃል ላይ ስትቆርጡት ያለው appearance ነው የሚሆነው ማለት ነው። It's a morphologic description. You'd also appreciate portal hypertension as a result of congestion. You would see congestive splenomegaly as a result of portal hypertension, and you'll have transudative effusion within the pleura, በጣም የሆነ peripheral pooling የሆነ ካለ ማለት ነው peripheral pooling of blood ካለ you would see basically diffusion of fluid into the extracellular space. It can be into the pleura, the pericardial, the peritoneal spaces, and sometimes even into the subcutaneous tissue edema. Massive compression. So you will see that. So right-sided heart failure or colpulmonale, if it occurs isolated ከሆነ usually secondary to chronic pulmonary problems. You will have distended jugular veins, anorexia, complaints of GI disease, weight gain. This can be the manifestations. So ischemic heart disease is basically the symptoms that result from myocardial ischemia, an imbalance between myocardial oxygen demand and the blood supply. And the most common cause is the narrowing of the coronary arteries by atherosclerosis. So the clinical manifestations are at major forms. The first one is the angina pectoris. You have different variants. And you have the myocardial infarction. This is actual days of the heart muscles as a result of ischemia. And then you have sudden cardiac death, which is a clinical syndrome that is characterized by just sudden death following massive ischemia. Or chronic ischemic heart disease with congestive heart failure resulting in pump abnormality, or like that abnormal dilatation of the vessels, anything. That's a chronic ischemic heart disease leading to congestive heart failure. So it can present in any one of these manifestations. So from all of these, the ones that can be acute or sudden manifestation are angina, specific type of angina known as unstable angina, and then acute myocardial infarction, and then sudden cardiac death. And as these two are forms of acute coronary syndromes. So the pathogenesis is that diminished coronary perfusion related to the myocardial demand. So as you know, these are the major arteries that supply the ventricles and also the atriums as well. So we have, this is the aorta, just distal to the aorta, the coronary arteries start. And you have the right coronary artery and you have the left coronary artery, which then bifurcates into two major branches. That is the left anterior descending artery, and then you have the left circumflex artery. So these three branches are the major arteries that cover the at least a significant portion of the wall of the heart. So atherosclerosis, this is a revision, is like 90% of the cases of ischemic heart disease occur as a result of atherosclerosis, coronary atherosclerosis. Okay. So ischemic heart disease, in a case of a stable one, usually results in chronic ischemia. So the manifestation is that. In the unstable one, you can see acute myocardial infarction as a result of rupture and sudden occlusion of the vessel. So another also acute complication in the case of a ruptured and an unstable one, you will see acute myocardial infarction. But for the stable one, where there's not a lot of critical stenosis, you wouldn't expect much more symptomatic disease, but the progression can result in a sort of chronic ischemic heart disease. So severe chronic atherosclerosis that causes narrowing of the lumen, or one more chronic, is the fundamental disorder underlying ischemic disease. So critical stenosis, CDARS, then it causes a symptomatic disease. So either angina, that's just chest pain. We'll see that later on. Acute plaque changes result in sudden occlusion of the vessels. So it results with much more drastic clinical presentation. Okay. So this is just what we have seen earlier. Another coronary artery thrombosis is also one of the big changes. Other than atherosclerosis, another cause of coronary artery obstruction is something called the coronary artery vasospasm. And it occurs in patients with some pre-existing atherosclerosis, but it can also occur independently on its own. And it's usually induced by these chemical mediators from platelets. And it's just the vessel becomes vasospastic, and it is like constricted, acutely constricted, and it can cause obstruction and then ischemia. Other pathologic processes that we expect are emboli originating from vegetations in the aortic or the mitral valves. As you know, the coronary arteries are direct branches from the aorta. So let's see, any sort of detached ያደረገ thrombus can get access into the coronary arteries, or even ostiamun ራሱን ሊዘጋው ይችላል ማለት ነው, resulting in ischemia, major branch ischemia ሊመጣ ይችላል. And then you have severe የሆነ systemic hypotension. So በጣም hypotension ጋር shock ማለት ነው, mainly as a result of cardiogenic shock ካለ, then blood cannot reach the heart muscles, so that leads to ischemic heart diseases. Or it can be due to increased myocardial oxygen demand, due to hypertrophied heart muscles, pressure overload. And then we met up with hypertrophied heart muscle, increased demand, it can result, makes it much more vulnerable to ischemia, and it can result in ischemic heart disease. So when you look at the clinical presentations, the first one is angina pectoris. Angina pectoris just simply means chest pain, but it is a specific type of chest pain that is substernal, and sometimes it's even felt as a kind of heartburn or a kind of epigastric pain. And it is usually transient. It doesn't last beyond 15 minutes. And it's just myocardial ischemia that falls short of infarction. Then that means there will not be actual muscle deaths. Okay, there's no like tissue damage lost. Reversible የሆነ ነገር ነው እንጂ actual damage አይኖረውም ማለት ነው። ግን because of the ischemia is usually painful, the patients have it. There are three major variants of this chest pain. You have the typical or the stable angina pectoris, in the prinzmetal angina, and the unstable angina pectoris. This is basically the distinction between these variants is mainly on how long it lasts, and also whether it responds to painkillers, particularly nitroglycerin, and nitroglycerin is a vasodilator. So any sort of narrowing usually responds to this vasodilator. So ለሱ ይመለሳል አይመለስም የሚለው ነገር ነው ሪስፖንድ የሚያደርጋቸው. The typical one ቅድም ዲስከስ እንዳደረግነው ነው, doesn't last long, and it's also በጣም highly responsive to anti-pains, and it is associated with a fixed የሆነ atherosclerotic narrowing that is a stable plaque ማለት ነው. So with the degree of obstruction, critical stenosis, the myocardial oxygen demand may be adequate under basal conditions, but it cannot be augmented under stress. So another typical manifestation of a stable angina is that it is precipitated by an increase in the demand. ስለዚህ ኤክሰርሳይዝ ሲያደርግ የሚብዝ አትሬስት ላይ ደግሞ የሚጠፋ አይነት ነው the typical angina. It's usually relieved by rest, reduced demand, or by the administration of nitroglycerin. Prinzmetal or variant angina lasts slightly longer than the typical angina, and it also responds very much well to vasodilators. Unstable angina pectoris is due to mostly the vulnerable plaques that we have seen before, and it's sometimes also called crescendo angina because progressively increasing እያደረገ የሚሄድ ነው, and it doesn't really respond to vasodilators, and it's more intense and it often lasts longer than the stables of the episodes of the two variants of the stable angina we have seen before. So it's in more patients, it's induced by acute plaque change, superimposed either thrombosis, embolization, or even the presence of a vasospasm because of the release of those chemicals. So the next form of ischemic heart disease, other than the pain, is myocardial infarction. It's actually myocardial necrosis. There's tissue damage and tissue loss that is caused by this local ischemia. It's also known as a heart attack, and it's also one of the commonest cause of deaths in the Western world. I think like 7 million people die every year because of myocardial infarction. So the patterns of infarction can be transmural, that means involving full thickness of the ventricular wall. Because the endocardial can be a subendocardial or non-transmural impacts, which is limited only to the inner 1/3 of the ventricular wall, and it can result from an acute plaque change or something, or it can be multifocal microinfarction where the damage is involving multiple sites. So here, transmural impacts, endocardium all the way to the epicardium, involving at least one side of the heart. And again, transmural, another one involving the free wall, here involving one of the walls in the interventricular septum. In this C, you will also see only a part of the endocardium and the myocardium is involved. So transmural infarcts are usually due to permanent occlusion of one of these supplying arteries, okay? One of these arteries. Permanent occlusion ካለ ነው transmural የሚኖረው, but non-transmural infarcts where circulation can be established, you can't spare a certain part of the myocardium in the heart muscle. So in that case, you will appreciate these non-transmural infarcts where only the inner third is involved. Here you see a kind of circumferential infarction, but it's a kind of incomplete occlusion of the vessels here, here, and here, okay? 3 vessels are involved, so it's kind of circumferential. It involves all walls of one ventricle, but because it is partial, you expect the infarction to be limited to the inner side of the wall. And then this is what we call the multifocal infarction, where you see just spots of ischemic death usually as a result of occlusion of the tributaries of these major branch. Rather than a major branch occlusive amharic, there's more intramural vessel occlusion ሲኖሩ ነው እንደዚህ አይነት myocardial infarction የምትመለከቱት ማለት ነው። So the major risk factors for MI are the same as those for atherosclerosis, modifiable, non-modifiable, because atherosclerosis is really the most significant cause of coronary artery disease anywhere. ሌሎቹ ቅድም ያወራናቸው ዝም ብሎ coronary artery vasospasm or just embolized from the vegetations inside the ventricles. እነሱ በጣም only like 10% of the cases ነው account የሚያደርጉት. Mostly it's atherosclerosis. So what happens? What's the myocardial response to ischemia? So when there is hypoperfusion, how does our heart muscles respond? So this just gives you the timeline. You can read it. So the classic myocardial necrosis with extensive damage, it begins approximately 30 minutes after the coronary occlusion. But the classic MI occurs when the occlusion lasts beyond 2 hours, okay? So the precise location, the size, and morphologic features will depend upon the type of the obstruction, also the duration of the occlusion. Sometimes occlusion ይኖራቸውና ሰዎች ይመጣሉ, but if you like dilate the vessel or procedure ምናምን ከተሰራላቸው, you might actually avert a serious myocardial infarction. So as the duration matter ያደርጋል, and also the metabolic or oxygen needs of the myocardium, at least the larger it is, then the severity of the myocardial infarction is supposed to be is going to be larger, and the extent of collateral blood vessels. So you have sometimes in the case of chronic ischemia, collateral vessels are formed just like any other tissue. If there is a chronic ischemia, and if that side of the heart where you where occlusion occurs, occlusion ያለበት area surviving supply የሚያደርገው area ላይ collateraloች ካሉ, then the consequence of the myocardial ischemia can be a little bit less. And the presence of site, the site and the severity of coronary artery spasm, already obstructed vessel light, if there are spastic responses, then that even worsens the occlusion, and that's the ischemia. And other factors, change in the blood pressure, the heart rate, the cardiac rhythm, all of these are the conditions that increase the workload of the heart. So if there's like a change in this, particularly on the positive side, then the myocardial ischemia is more likely to be more. Okay, so these are very important parameters to look on if you want to know about the severity of myocardial ischemia. So the location of an MI is determined by the site of the vascular occlusion and by the anatomy of the coronary circulation. So occlusion of the left anterior descending coronary artery supplies what? The left ventricle in the anterior ventricular septum. Let's see here. Here it is. So የቱ ጋር occluded እንደሆነ ማተር ያደርጋል ማለት ሳይቱ occlusion የቱ ጋር appear ያደርጋል. So the more proximal it is, then the more surface area that the ischemia in the infarction occurs, the more distal it is, the more narrow it is. So this is the left coronary artery, the circumflex and the left anterior descending. እዚህ ጋር ከሆነ the area that's covered is this side. So it will be ischemic ማለት ነው. Okay. And here you see the progression of the ischemia. So within the first 2 hours, inner side more ischemic infarction, and if the occlusion persists for the next day, 24 hours ሙሉ transmural infarction ይሆናል ማለት ነው። ሲጀምር ግን የሚጀምረው more on the inner wall of the heart ነው ማለት ነው። So the gross and microscopic appearance of an infarct at autopsy depends upon the duration of the survival of the patient for the MI. And so the area of the damage, they undergo a sequence of morphologic changes that is mostly characterized by coagulative necrosis, just like any ischemia, it follows by coagulative necrosis. So within the first 4 hours, you would not really appreciate gross or microscopic changes. This was basically the normal heart. But after 4 to 12 hours, you would see occasional dark mottling, which is like a kind of hyperemic or spotty response. And that shows the beginning of the coagulative necrosis. So here you see the normal heart muscles here, and here more pinkish coagulative necrosis, as you know. is a type of necrosis where the outlines of the cells are maintained. Morphologically ስታዩት ስለዚህ the outline of the cells እዚህ ጋር ስታዩት muscle fiber ያለው ይመስላል ግን it's much more pinkish and there are a lot of nuclei that are dead and that are pycnotic here. So within the next 12 to 24 hours, you would expect dark mottling, which is a reflection of the coagulative necrosis here. I will show you what mottling means. And then there will be ongoing coagulation necrosis. It's much more pink than you would expect here. So the coagulation outlines of the things remain maintained, but if you see this chunk of the heart muscle, it doesn't even have a nuclei. So most of them are dead or dying. And one of the very important characteristics of necrosis is that it is followed by an inflammatory response. So you would start to see neutrophilic infiltrates at this stage. So grossly, that hyperemic or the mottling stage becomes much more pale with some hyperemia, particularly in the peripheral zones of the ischemia. So here is a heavy neutrophilic infiltrate, and as in the usually neutrophils. So that is accompanied by a heavy neutrophilic infiltrate. Here again, a completely dead tissue, massive neutrophils, hemorrhage. Okay, yeah, hyperemic appearance in የሚፈጥረው is just basically hemorrhage into the dead tissue happen ስለሚያደርግ ነው ማለት ነው። Grossly hyperemic or ቀይ የሚመስለው ማለት ነው። So within the next 3 to 7 days, you would appreciate on grossly this infarct, a pale area in the middle, and a hyperemic area where you have these hemorrhagic responses. We'll see base. Again here, heavy neutrophilic infiltrate. This is a derby. ቆሻሻ ነው ማለት ነው የሞተው ኒውክሊየር ማቴሪያሎቹ along with neutrophils ማለት ነው። ስለዚህ basically it's just a necrotic tissue ማለት ነው. So within the next 10 days, you will see maximally yellow, soft, depressed tan margins. So just like እንደሌላው inflammation subside ያደርጋል አይደል? And once these debris is removed, there will be by phagocytosis of the dead cells, and there will be early formation of a granulation tissue that is a proliferation of the vessels and deposition of fibroblastic tissue. So scar tissue ይመጣል ማለት ነው. That's where you have the scar tissue formation. 10 to 14 days, you will see depressed infarct borders and well-established granulation tissue. Granulation tissue is formed by these capillaries, the small capillaries, and the inflammatory cells, the chronic inflammatory cells that you see in the background of another normal intact heart muscles ናቸው. And this is the granulation tissue. በኋላ scar tissue የሚሆኑ ማለት ነው. And then you have a kind of sclerosed or fibrotic background, which is going to solidify the scar tissue as it progresses. So the fibroblastic proliferation will continue to increase the collagen deposition and cellularity ይቀንሳል. Okay, all of the inflammatory cells will be resorbed, and then የሚቀረው scar ይሆናል ማለት ነው. Just the collagen deposition with decreased cellularity. And by 2 months, all scarring is complete, and you would see a more dense collagenous scar. So here you have a scar tissue ማለት ነው. So as you know, myocytes do not regenerate, so that once they are lost, they cannot be replaced. It's just going to be a scar tissue here. So those are cells that are permanently lost. እነዚህ normal fibeሮቹ መሃል ላይ ታዩታላችሁ, and then pale whitish area የሆነው represents the scar tissue. So am I classical by typical symptoms accompanied by severe crushing, the substernal chest pain, and the chest pain usually lasts hours to days, and it's not relieved by nitroglycerin. And the pulse is generally rapid and weak, and patients often are diaphoretic. Can anybody guess why patients become diaphoretic in the case of myocardial ischemia? Why do patients become diaphoretic in ischemia? I think everybody stopped listening. I expect an answer at the end. So shortness of breath is common, and this is due to is mostly systolic dysfunction. And when with massive MIs involving over 40% of the ventricle, then you have a cardiogenic shock. ምክንያቱም በጣም ትልቅ chunk of the heart muscle is not functioning anymore. So when the heart is not functioning, it cannot maintain the systemic pressure. So let's see, it fails and it results, they become hypotensive. In a minority of patients, the MI does not cause this chest pain, and they're called silent MIs. They're particularly very common with diabetic patients, where they have, due to the hyperglycemia, they have some sort of autonomic blunting or some sort of autonomic neuropathy. So they cannot really feel the pain. So silent MIs, these are MIs that are ongoing but are left. So they are more likely to cause a sudden cardiac death in patients with diabetes. And MI is the commonest cause of death in diabetic patients worldwide. So you can see if the presence of myocardial infarction by evaluating proteins that are released from the myocardial cells as they die. And these are the myoglobin, the cardiac troponins, and as in monitor በማድረግ we can see the level of infarct and also the stage of the infarction that the person is in, and we can follow the patient with these. So they're very important laboratory markers to evaluate myocardial infarction. And this is also how you distinguish if there is an actual myocardial infarction or it's just an unstable, a kind of pre-infarct angina. If you want to make a distinction between those two, you have to do these laboratory tests. They show myocardial damage. So complications of MI, it can lead to cardiac arrhythmias, and mostly leads to arrhythmias because of the damage or even the death of those specialized myocytes you guys were talking about. So conduction abnormality vetralut, so they might result in arrhythmias. And they might result in left ventricular failure, particularly with the mild to severe pulmonary edema, congestive heart failure, cause and again, a major change of the ventricular wall fail cannot maintain the pressure and results in cardiogenic shock. And there might be a rupture of the free wall, the septum or the papillary muscle. This is due to the death or the loss of myocytes. Okay, the transmural infarction heart muscle will be lost, and that can result in aneurysms followed by rupture. And the rupture can also occur in the septum, the intraventricular septum, or even in the papillary muscles that kind of hold the valves together. And if there is a rupture in the papillary muscles, then you'll also see valvular insufficiencies as well. Thromboembolism can occur as a result of myocardial infarction. This can be due to aneurysms, stasis, and then the thromboembolism situation. Pericarditis can occur due to myocardial infarction, ventricular aneurysm, and so on. Here we see a rupture of the free wall of the ventricle. Here we see again a defect on the intraventricular septum, as you can see. Here we have the rupture of the papillary muscles, pericarditis, you will see, and then there's also thrombus formation within the wall. And again, massive የሆነ cardiac muscle loss ካለው it can be thin out ሊያደርግና aneurysm ሊፈጠር ይችላል ማለት ነው። So when it becomes chronic በሚሆንበት ጊዜ it's also called ischemic cardiomyopathy በጣም like acute የሆነ የተጫጫሰ drastic manifestation አይኖረውም. It's kind of a long-term ischemic cardiac injury. So many cases are associated with some history of angina pectoris ይኖራቸዋል unless like that critical stenosis escalated ድረስ ብዙ ጊዜ symptomatic አይሆንም. So sudden cardiac death is defined as unexplained death that comes from these cardiac causes without any symptoms, and it's commonly due to arrhythmias, ventricular fibrillation that result in sudden cardiac death because there is no more transmission of impulses. So other than atherosclerosis, sudden cardiac death can also occur in other conditions, developmental anomalies, aortic stenosis, or any other form of ventricular outflow obstruction. But predominantly in these cardiomyopathies, if you have heard of these hyperplastic cardiomyopathy, so in young athletic individuals, more likely to result in sudden cardiac death. Okay, so the next ones which I will try to see shortly are valvular heart diseases. So the valvular heart diseases are mainly two pathologies. There is a stenosis, failure to open, and regurgitation, which is failure to close. So can you look at this animation and tell me what you see? Which side has regurgitation abnormality and which side has a stenotic abnormality? Say just right and left. Right has this. And if you can name the valve, that would be good too, that you see pathology in. I see two valves that work just fine, and I see two valves that have abnormalities, valvular abnormalities. So I'm going to give you a second to look at that and answer the question. Okay, mitral valve is leaking. Good. And any lesion on the tricuspid valve? Inferior vena cava. Yeah, there is some pathology somewhere in the inferior vena cava. somewhere around here. What do you see? It doesn't open easily, right? What is this chamber? That's the right atrium, right? Yeah. The right atrium. So what is the bulb between the right atrium and the right ventricle? That appears to be stenotic. Tricuspid valve. Okay, thank you. So I think you got these lesions down. So they impose a major hemodynamic burden, either pressure or volume overload limit, and abnormal valves are more susceptible to infection, because they're more likely to have endothelial damage. They are more exposed to anything what the circulation has to offer. So any circulating bacteria exposed of course. They are more prone to infections and inflammatory process as a result of damage, endothelial damage. So abnormalities of flow often produce abnormal heart sounds known as murmurs. So regurgitative lesions usually result in systolic murmurs, like additional sound other than the systolic sound, the laptop sound that it makes, because the leaking in regurgitation murmurs occurs during the systolic phase. So you will see through chamber or flow or leak you'll be able to appreciate it with your stethoscope. And but now nobody really does those physical examinations anymore. So the diseases of the heart valves include diverse group of acquired congenital lesions, some of them in isolations, and other occur in associated with other abnormalities or acquired ones. So the major functional lesions are aortic stenosis. Aortic stenosis can happen a calcification of anatomically or congenitally bicuspid aortic valves. Aortic calcification is usually, it can happen with an increase in age, okay, because against high pressure valve ስለሆነ ብዙ ጊዜ የማጎዳት ከዛ በኋላ ዲጀነሬቲቭ ቼንጅ የማድረግ ደግሞ ትንሽ ቻንስ ስላለው ነው። but if it is like severe, it causes functional abnormality. Aortic insufficiency is the dilatation of the aorta related to hypertension or any sort of aging. Mitral stenosis, usually associated with rheumatic heart disease, and mitral insufficiency can also be related with rheumatic heart disease, but it can also be due to a degenerative change within the wall of the valve itself. Means some of this degeneration is kind of flimsy or not, it won't close properly. So that's what's known as mitral valve prolapse. So what abnormalities would you expect in the case of a mitral stenosis, for example, which we would see in rheumatic heart disease? What do you think will happen within the blood vessels? Progressive የሆነ mitral stenosis ካለ, what do you expect to happen? ምን አይነት ሄሞዳይናሚክ በርደን ያመጣል? ምን አይነት ኮንሲኩዌንስ ታስባላችሁ if there is mitral stenosis? በደንብ ኦፕን አያደርግም, so you don't have what would you expect? Just briefly think over. Pulmonary congestion, that's but I'm way down the road. Can you tell us how it gets to pulmonary congestion? What do you first expect to happen? What hemodynamic change would you expect to happen? Pressure overload, volume overload, what do you expect? And in which chamber would you expect it? Left ventricle. Why do you say that, left ventricle? Yeah, pressure overload in the left atria. That's exactly right. Yeah. Left atrial pressure increases, and that results in translating into the pulmonary veins, and that goes back into the pulmonary circulation, resulting in pulmonary congestion. What if it is a regurgitant lesion? MR ልክ እዚህ ላይ እንዳለው ቢሆን what do you expect? Is it going to be hypertrophy of the left ventricle or the right ventricle only? The pressure is now in the pulmonary circulation, so it translates to which side of the heart? I'm confused. Are we talking about the regurgitative lesion or the stenotic lesion? Stenotic lesion, which side of the heart would you expect the hypertrophy in for the stenotic lesion, for mitral stenosis? Atrium doesn't really hypertrophy, it's rather it just dilates. It dilates. But you expect hypertrophy in stenosis. I'm asking which ventricle. Okay, so we'll talk about this in our face-to-face discussions. Let's move on. You get the idea that how valvular lesions are a hemodynamic burden to our heart. Rheumatic fever is a kind of specific type of immunologically mediated inflammatory disease that is particularly caused by this bacteria, group A streptococcus. So it is group A streptococcal pharyngitis causes a kind of an upper respiratory disease. Okay. It's just called pharyngitis no but the antibodies that are formed against a specific part of this bacteria will cross-react with antigens that are present in the surface of the valves. So you have cross-reactivity. Antibodies that are formed for this bacteria will cross-react with these antigens and result in an inflammatory response. So let's say you don't actually have introduction of the bacteria to the cardiac muscles. It's rather an immunologically mediated inflammation. It's the antibody that actually results in the valvular heart damage. So strongly suspected that acute rheumatic fever is a hypersensitivity reaction, and the antibodies directed against the M proteins of the group A streptococci kind of cross-react. So a person becomes, the infection is usually introduced by inhalation, so they will have a sore throat infection in oral, and then several weeks later, they might have acute carditis symptoms when antibodies that are formed for this particular insult will attack the heart, in the endocardium heart, particularly the valvular surface. So not just the endocardium and the valves are involved. In fact, the immunologic response involves the entire wall of the heart and the endocardium and the valves, and it also includes the myocardium and even can result in pericarditis. So it's a kind of pancarditis, inflammation of the entire wall of the heart muscle. The chronic sequelae results from progressive fibrosis due to both healing of acute inflammatory lesions and also the turbulence that is induced by the valvular abnormality. Flow disrupt. So rheumatic fever particularly is characterized by these lesions, these amblyons, characterized by pancarditis. And the pancarditis, that means endocardial vegetations, that means inflammatory cells accumulate in just at the cusp of the valves in the endocardium and also in the septum sometimes. And also you will have inflammatory response within the muscle, and in the muscle, the particular type of inflammation pattern we would accept is what's known as an Ashov body. An Ashov body is composed of these fibrinoid degeneration, of the heart muscles, and then you have these macrophages, giant cells that are known as Anichko cells, and also you have plasma cells. So all of these together, the fibrin, inflammatory cells, the plasma cells, and the specialized macrophages form the Ashov body, and they are characteristics, almost pathognomonic for a rheumatic carditis, rheumatic myocarditis. Here we see the Achkau macrophages, the specialized macrophages here, like here, and this entire thing is the Ashov body. Again, these are macrophages. They have a very specific basophilic type of cytoplasm, and they are very characteristic for rheumatic carditis. So you have vegetations in the valves, you have the Ashov bodies in the myocarditis, and you also have like pancarditis and epicarditism is also involved. So you would see inflammation of the pericardial tissue here, and it is characterized by this rough surface. Pericardial exudate ስለሚኖረው that is inflammatory response, fluid የሆነ inflammatory response ነው። ራፍ የሆነ normally ስታዩት እንትን ነው፣ በጣም smooth ነው pericardial tissue. It shouldn't be like this. It shouldn't be rough መሆን የለበትም. It has this bread and butter appearance. That means ዳቦ ቀብታችሁ አጣብቃችሁት መልሳችሁ ስታነሱት ያለው የሆነ ጭብርር ያለ ሰርፌስ አለ አይደል? ልክ እንደሱ appear ያደርጋል morphologically. So it's called a bread and butter pericarditis, which is characteristic for, again, rheumatic pericarditis. So myocarditis takes a form of Ashov bodies, and they form small vegetations or vericai. These are basically just inflammatory cells. Nasu recruit edematous response, and then a little bit of a clot tissue. So just like a sterile thrombus. And they're called vegetations, and you usually find them at the edges of the cusps of the valves. ስቴኖቲክ ሊዥንም የሚያመጡት በኋላ ስካር አድርገው እርስ በርስ ይጣበቃሉ። ኦር ደግሞ በጣም ስካር አድርገው በጣም ሎስ ኦፍ ቲሹ ካለ ደግሞ በደንብ ሙሉ ለሙሉ መዘጋት ያቅታቸዋል። ስለዚህ ኢንሰፊሽንሲ ያመጣሉ ማለት ነው። So these are responsible for the valvular heart lesions. So chronic rheumatic heart disease is characterized by the organization of acute inflammation and also subsequent fibrosis, and you will see the valvular lesions. And then valvular lesions, የሚመጡት hemodynamic abnormalities are basically the manifestation of rheumatic heart disease. And in our patients, particularly in pediatric patients, is one of the commonest cause of congestive heart failure. Okay. So here you see these raised lesions natural. They're not that big, but I'm raised lesions natural, nodular lesions natural. This should be normally very smooth. Appropriate in smooth one, but when you see these bumps everywhere, those are the vegetation. But you see here, this is በደንብ ያልተዘጋ bicuspid የሆነ valve ነው ማለት ነው. You see an opening here causing insufficiency. And then here again, another insufficiency. So the mitral valve is abnormal in approximately 95% of the cases. So we expect a lot of a response, or the mitral valve to be much more involved, because it is one of the vessels that opens under high pressure. The next one is the aortic valve. ስለዚህ high pressure ላይ open የሚያደርጉት በጣም exposed ይሆናሉ for any sort of antibodies that are delivered through the circulation. ስለዚህ እነሱ ናቸው more involved የሚሆኑት mitral valve and aortic valve. So right-sided የሆነ valvular disease is relatively uncommon. Okay. Damaged የሆኑ valves predisposes to another condition called infective endocarditis. Rheumatic fever occurs clinically. የመጀመሪያው manifestation ዝም ብሎ tonsilopharyngitis ነገር ነው የሚያመጣው. Lasts a couple of days and then heals, and then 6 weeks after that you will see some manifestation of rheumatic heart disease, immune reactions are more limited. The manifestations of the heart disease are a little bit progressive and they can last a bit longer. So at the time where the patient develops rheumatic carditis, the cultures for streptococci are negative. The damage is mostly mediated by the antibodies. So you would appreciate antibody tests more than an actual infective agent. So the criteria to diagnose rheumatic fever is called Jones criteria. We have the major manifestations and minor manifestations. The major manifestations actually show that it is much more of a systemic disease, antigen antibody reaction. So ሌላ cross react የሚያደርግባቸው areas like the joints, the subcutaneous tissues, in the skin, even in the nerves ማለት ነው ኮሪያ እነሱን ላይም ሄዶ cross react ስለሚያደርግ you will see systemic የሆነ immune autoimmune manifestations. So those are major manifestations that tells you it is a systemic disease. Minor manifestations, fever, arthralgia, elevated blood levels of acute phase reactants, it's a minor manifestations. So if you have like 2 major criteria or 1 major and 2 minor criteria, you can diagnose rheumatic heart disease or rheumatic fever in particular. The heart disease, as I tell you, is much more chronic manifestation. So okay, so most of it is the things that you can read on your own. So since we have gotten way past our time, I'm going to leave these next portions for you guys. I'm going to share the presentations, and then if we have some time in your next lecture, I will go through them very briefly. Infective endocarditis. Okay, so let's just stop here.
Okay, thank you, doctor. If there are any question, we'll present on the next face-to-face classes.
Okay, so I'll see you then. Thank you.
Okay, thank you.